I'm Deb Adey, part of the CEoT Planning Committee. I'd like to welcome you to the Breakfast Symposium, Unraveling the Role of the Complement System in Kidney Disease, sponsored by Novartis. On behalf of the AST, I'd like to thank Novartis for their support of the CEoT meeting. Thank you. Please welcome the symposium speakers, Dr. Srini Srinivas, Senior Medical Director, Nephrology, Innovative Medicines, U.S. Medical Affairs, Novartis Pharmaceuticals Corporation, and Susan K. Lostetter, who is Medical Science Liaison Director, Innovative Medicines, U.S. Medical Affairs, Novartis Pharmaceuticals. Thank you both for attending, and thank you for those who are here.
Thank you again for braving the early morning on the last day of the CEoT conference to join us this morning for this educational symposium. Again, my name's Susan Lostetter, and I'm going to have to figure out how to advance the slides. There we go. I'm a physician assistant by training. Did my transplant work right up the road here at Mayo Clinic in Arizona before joining Novartis Pharmaceuticals as the medical science liaison that supports this area. And I'm absolutely thrilled to be joined by my colleague, Dr. Srinivas, who many of you in this room probably know. He's done a ton in the transplant world. Transplant nephrologist himself, practiced across multiple academic centers, most recently before joining Novartis as the medical director of Case Western Reserve University in Ohio. And his scholarly research activities have been experienced far and wide, everything from clinical pathological correlates, renal allograft biopsy studies, biomarkers, immunosuppression, the list goes on and on. So I'm thrilled to have him here today as my co-presenter, and we hope that you'll find this disease state educational symposium very valuable. Couple more housekeeping items before I dive in. First of all, as mentioned, this is a disease state only talk. And because of that, we will not be discussing any specific therapeutics, and we will not be able to answer any questions about therapeutics. So we appreciate your understanding there. At the end, we will save some time for questions. And again, as I mentioned earlier, for those who are just coming in the room, we do have a pre and a post-test survey that we greatly appreciate your comments on so that we can continue to improve these educational programs. So with that said, I'm going to go ahead and get started on the presentation. Here's an overview of what we plan to discuss today. First, just an introduction to the complement system and complement-mediated kidney diseases. Then we'll take a little bit of a deeper dive into the complement system, and then discuss how dysregulation of the complement system can lead to kidney disease. Lastly, Dr. Srinivas will walk us through a deeper dive into specific complement-mediated kidney diseases, including IgA nephropathy and C3 glomerulopathy. So for that quick introduction, I think everyone in this room is well aware that the complement system plays a key part in the immune system. It's a central pillar to innate immunity, but it also acts as a bridge to our adaptive immunity. When it's appropriately functioning, the complement system activates and maintains homeostasis and can eliminate infectious microbes while hopefully avoiding any damage to the tissue or the organs. However, a dysregulated complement system has the potential to cause autoimmune diseases, cause inflammation, ischemic disorders, hematologic disorders, including certain glomerular diseases. The dysregulated complement system is gaining more and more attention as a driver of the pathophysiology of several primary genes. Collectively, these are being called complement-mediated kidney diseases. Here's a list of a few of these, and the ones bolded in the middle, specifically C3 glomerulopathy and IgA nephropathy, we will have time to discuss a little bit more during today's presentation. So why is it important to focus on complement-mediated kidney diseases? Well, in part because they can have such a substantial burden on the patient. For example, C3 glomerulopathy, 30 to 50% of patients will progress to end-stage renal disease within 10 years of a diagnosis. In addition, patients with IgA nephropathy who have a gram or more of proteinuria a day progress at nearly the same rates, again with 30% of those patients developing kidney failure within 10 years. While IgA nephropathy is considered bread and butter for most nephrologists, these are, in the grand scheme of things, more rare diseases, particularly C3 glomerulopathy, which has an incidence of 2 to 3 cases per million people per year. And when diseases are rare, we find that it can be more challenging for those patients to eventually get a diagnosis, which, as you can imagine, can have a substantial burden when there's a delay in period of time to getting that diagnosis. So now I'm going to go ahead and dive a little bit deeper into the complement system. And the first thing I'm going to do is play a video here. And it looks like it's going.
The role of the complement system as a driver of chronic kidney disease is often under-recognized. Complement-mediated kidney disease can result in loss of kidney function, requiring dialysis or a transplant. The kidneys are particularly vulnerable to complement-mediated injury due to structural features of the glomeruli. The complement system is part of the innate immune system, but uncontrolled activation or dysregulation can cause inflammation, tissue damage, and loss of kidney function. The complement cascade can be initiated through 3 pathways: classical, lectin, and alternative. The 3 pathways converge at the level of C3. Cleavage of C3 to its activated form, C3b, leads to the formation of inflammatory mediators and the membrane attack complex, which can cause cell lysis. The classical and lectin pathways are activated in response to specific triggers. Under normal physiological conditions, the alternative pathway is continually active at a low level and can act as a powerful amplifier of the classical and lectin pathways. Complement overactivation within the kidneys causes damage to glomerular tissues and plays a key role in the pathophysiology of many kidney diseases.
So hopefully a picture, or a video in this case, is worth 1,000 words, because the complement system at first glance appears incredibly complicated, reminiscent, at least in my mind, of the clotting cascade. As mentioned in the video, there are 3 separate pathways that can lead to activation of the complement system. There's also 3 phases in the complement cascade. The first one can be thought of as the activation phase. The next, the amplification phase, propagation of some of these signals to continue these inflammatory pathways. And lastly, the terminal sequence, which most of us remember resulting in the formation of the membrane attack complex, that series of proteins that can actually poke holes in cell walls, cause cell lysis and cell death. We want to take a little bit closer look at each of these phases in the complement cascade by first emphasizing that each of the pathways has a different trigger. For example, the classical pathway is triggered by the formation of antibody-antigen immune complexes. The lectin pathway reacts or is activated upon recognition of mannose-rich bacterial walls on injured cells as well. The alternative pathway is actually unique in that it's constitutively active, meaning that it's always active via this phenomenon called the tick-over. Essentially, what's happening in the alternative pathway continuously at a low level, everyone in this room is experiencing this, is that the C3 C3 protein in the complement cascade is hydrolyzed into an active form. The next phase or step in the pathway is the convergence of actually all three pathways once activated into the formation of a C3 convertase. C3 convertase is an enzyme, as the name suggests, that breaks down C3 into its active components. One thing that is very unique about the alternative pathway is that there is a specific C3 convertase that continues to cause amplification of the pathway and ongoing propagation of signaling and ongoing downstream effects. Factor B is a protein that's specific to the alternative pathway, and it is the breakdown of factor B that you see here in yellow by factor D into its active components that go on to form the C3 convertases of the alternative pathway, including this amplification loop that has a significant effect on the ongoing activity of the complement system. Lastly is the terminal pathway. These convertases, when they break down C3 and C5 into their active components, result in a couple of different actions. The first is the formation of anaphylotoxins, and these obviously go on to be responsible for quite a bit of inflammation. When C3b then contributes to the formation of C5 convertase, this breaks down C5a into an anaphylotoxin to cause more inflammation in addition to C3a, but then also contributes to the formation of that membrane tack complex, or that terminal part of the cascade that can perform direct cell lysis. So now we want to talk about how a dysregulated complement system can lead to kidney dysfunction. There's a couple of different ways that this can occur. The first is by genetic abnormalities, mutations in the genes that code for specific factors in the alternative pathway that are important for keeping that pathway under control. And one thing I forgot to mention that's very important and really also differentiates the alternative pathway is because it is always active, it's important to have regulators or inhibitors, which are again proteins that basically put the brakes on that system to try to keep it under control so that it doesn't become overactivated and cause disease. Well, in patients that have complement-mediated kidney diseases, they could potentially have a genetic abnormality in one of those inhibitors of the alternative pathway. Factor H is a well-known example. And if that is not functioning properly, you may have the opportunity for the alternative pathway to continue out of control. Also, patients are known to develop autoantibodies to certain components of the complement system's proteins. If these autoantibodies cause a gain of function, if you will, in that protein, it could essentially increase the half-life of that protein, and something like a convertase, which is breaking down the other proteins into their active components, you can see how that dysregulation can get out of control. And why the kidneys? Why are we thinking of the kidneys? And in fact, complement dysregulation can certainly affect other parts of the body, but the kidneys appear to be particularly vulnerable for a variety of reasons. First of all, just the structure of the glomerulus and the fact that it receives so much cardiac output, full of complement proteins in the blood. Next, immune complexes can deposit within the glomeruli and are known to activate complement. In addition, The glomeruli can also produce complement proteins. We think most of those is being produced in the liver, but actually some are produced locally in the glomeruli as well. And then lastly, specific structures like the glomerular basement membrane do not have regulators or some of those inhibitors to put the brakes on the complement system once activated locally in the kidney. So again, a simplified picture, if you will, because believe it or not, the complement system has got at least 50 known proteins that contribute to all of these things happening in sync and helping support our immune system function. But as you can see, dysregulation, depending on the part of the complement cascade that is affected, can result in some specific diseases. A few of them that are rooted in complement dysfunction are listed here on the left-hand side. So how do we diagnose complement-mediated kidney disease? Well, just like any other GN or glomerular disease, renal biopsy is the gold standard to make the diagnosis. I know I don't have to tell anyone in this room the components of a renal biopsy, most likely, but just by way of review, light microscopy is used to assess overall structure, scarring, fibrosis, is there cellular proliferation? A step beyond that is the performance of immunofluorescence, which can stain proteins, either immunoglobulin or complement proteins, to give a little insight as to the potential cause of the complement-mediated kidney disease. And lastly, electron microscopy to really enlarge those structures and look at the patterns of deposition to help get both the pathologist and the nephrologist clues into the underlying cause of the kidney disease. Laboratory assessments are also very helpful, as everyone knows the importance of correlating pathology findings with clinical findings to try to get to the diagnosis in some of these challenging to diagnose rare diseases. These laboratory assessments are not diagnostic, but they can certainly provide good information to help clinicians get to that diagnosis. These include functional assessments of the complement system activity, levels of serum C3, C4, and then of course genetics if you're worried about an underlying genetic disease being the cause. Also, specifically when we think about immunofluorescence, there are some stains that are very commonly done by most pathologists. This includes staining of this complement C3 protein, C4D, and C1q. These are pretty much widely performed by most pathologists, and can give us a little bit of insight into which of the complement pathways may in fact be activated in the specific kidney disease that you're looking at. So by way of example, as we mentioned in the video, C3 is the common place where all of the pathways sort of converge. And so it would make sense that the presence of C3 by immunofluorescence in the renal biopsy could indicate activity of any of the three complement pathways. However, proteins like C4D that are more specific for the classical and the lectin pathway, if you have that in combination with the presence of C3, could clue into the fact that you may be dealing with a lectin or classical pathway dysfunction. And lastly, C1q, which is specific to the classical pathway, that also can give you a clue into the presence of all three of those, being that the classical pathway may be activated. Immunoglobulins are also stained via immunofluorescence and certainly do give clues in helping make that ultimate diagnosis. And the last part that I'm going to talk about before I hand it off to my colleague is some of these blood tests that are available to augment your ability to make a diagnosis. The functional assays, CH50, I'm guessing everyone in the room is comfortable with. That's pretty widely available and helps us ascertain how the classical pathway is working. AH50 may be a send-out test that is specific to alternative pathway activity. You can also measure serum levels of C3 and C4. That is fairly widely available. But when you look at those autoantibodies, otherwise known as nephritic factors, that may require a send-out test, but it can be done at certain specialized center where you can test a patient to identify if they have an autoantibody against one of these proteins in the complement system. And then lastly, specific genetic testing. So with that, thank you so much for your attention, and I'm going to pass it off to my colleague, Dr. Srini.
Thank you so much, Susan. Thank you. It's great to be here at CEoT and see a lot of familiar faces here. I was looking through some of my texts, and there was a text from David Foley saying, "Will you be at CEoT?" And I said, I don't know if we guys are in transplant meetings yet. And one of the things I pushed for after joining Novartis about 5 months ago was to say, hey, we started in transplant, we kind of left, but it's time for us to come back, and here we are. So that's where we are. I have to adhere to certain rules because I'm now in a therapeutic company and I have to play by a lot of rules, which is a foreign place for those of us you who know me. And so I'm not going to talk about anything about therapeutics. I can answer questions afterwards, but I'm not going to talk about therapeutics. And I'm also restricted in having slides that talk about two-kidney nephrology, which is also kind of a foreign place for me because I spent most of my career in transplantation and I came back into two-kidney nephrology because I felt that there's more to do here. And all of you know that these diseases come back in transplants, and you're transplanting people that have had end-stage renal disease from these diseases. So we'll start with IgA nephropathy. So the first thing that we all are taught as we start our training is that IgA is one of those things that comes when you have a sore throat, and if it comes with the sore throat, it's IgA. If it comes after the sore throat, it's post-strep. IgA is fine, it's benign, right? So I'm going to try and bust that myth a little bit here, because when you think about this disease, it's not as benign as people like to think it is. So the first thing here is that, the estimated annual incidence is about 7 to 21 cases per million. It affects younger adults, and they're usually 20 to 30 years more than the old and much more than older adults. And the older adults, surprisingly, actually seem to do okay if they develop the disease, really late in life, as opposed to the younger ones that I'll show you have problems. There's clearly a higher incidence in men, in 3 to 1 in North America and Europe. It's very different from the pattern that one sees in Asia. So the clinical presentation can be very varied. I don't like the word heterogeneous for purity because it kind of says that these things come from many sources, but that's what I'm restricted to. But it can range from asymptomatic microscopic hematuria to more severe sustained proteinuria, hypertension, and rapid deterioration of renal function. We're also finding out that the so-called asymptomatic microscopic hematuria is not as benign as you think it is, because some of those people can develop problems later in life. It depends on the age of onset and the gender and everything else. And those little things that are buried inside the textbooks actually come out to play when you start looking at outcomes in populations. There's a significant impact on quality of life. And a lot of these patients who are young, we see them as transplanters at the time when they failed their kidneys or they're being looked at for a living donor transplant, their dialysis or other things, or they might have received a previous transplant. We're looking at them. A lot of them, the history starts with having this sort of brain fog type feeling as things are going on. They're often sent to urologists to work up hematuria and so on. So lots of opportunities have been missed. And so now we are at a point where we understand this disease a little better. So IgA is in the moniker, right? So the pathology, so IgA immunofluorescence is out there, but what is buried is that an IgA deposit without a C3 immunofluorescence being present or a C4D immunofluorescence being present is not necessarily something that is called out as significant IgA. And it's buried there. That whole business of its association with complement is buried. Nobody talks about it as complement-mediated IgA nephritis. So this is where the narrative changes, and I'm going to show you how it's changed. We now think of IgA nephropathy as being driven by 4 hits. The mucosal-associated lymphoid tissue, or the MALT, is a very important site where, after an immunological trigger of whatever nature, an increased production of galactose-deficient IgA1 occurs. So the galactose is usually in the hinge region, and that production of galactose-deficient IgA1 is the first hit. The next hit is that because you have this abnormal protein being generated, the abnormal galactose-deficient IgA1, there's an increased production of autoantibodies against galactose-deficient IgA1. And when you have an antigen and an autoantibody, there's formation of IgA1 containing immune complexes. And the 4th hit is when this immune complex gets trapped in the mesangium and the glomeruli, and there is complement activation, which contributes to glomerular injury. And this immune complex deposition triggers a whole series of downstream pathways, including complement system activation, and eventually tubulointerstitial scarring, which, as you know, is bad. So let's dissect out the 4th hit. In IgA nephropathy, increasing amounts of evidence, and people have always known of this. Pathologists have known this for years. And I see Dr. Solis right in front here. Pathologists have known this for years, that complement is activated in this disease, that C1q is not present, that this is an alternate pathway problem. And if C4d is present without C1q, it's a lectin pathway problem. So they've known this for years. And so in IgA nephropathy, the alternate pathway is a big focus now, and somewhat less often it's the lectin pathway. But because of the convergence at the alternate pathway and the C3, there is an opportunity here. Let's put it this way, to understand the disease better. And those of you who see cartoons like this are already thinking about, how do I treat this? Which obviously I can't talk about. So, and it is important to note that it's not just in the glomeruli. Proximal tubular epithelial cells can also have problems related to complement, activation and, damage. And you can have tubulointerstitial scarring that follows, leading to end-stage kidney disease. And, starting first with glomerulosclerosis, arterial nephrosclerosis, and going on to, progressive renal insufficiency. I'm trying to move on. So now the C3A is felt to be one of the, to be related to mesangial proliferation, and C3BB increases as well, and then you get progressive glomerular scarring. And remember that what we've been able to use in the clinic so far has been restricted to a very late pathway inhibition. So those are things that are opportunities in the future. So as far as the pathophysiology of this disease goes, the lectin pathway and the alternate pathway dysregulation contribute to IgA nephropathy, which is what we know today. And 25% of patients with IgA nephropathy have mesangial deposits of lectin pathway factors as well. Mannose-binding lectin, L-phycolin, and MASP, which is mannose-binding lectin-associated serine protease, and C4d. And C3 glomerular staining, on the other hand, is present in 90 to 95% of IgA nephropathy biopsies, and it's co-deposited with IgA and propodin in the majority of patients. So the sad part about this disease, we know all this, these cartoons look very elegant to say, oh, we understand everything. The problem is many of these patients go undiagnosed until they're present with evidence of kidney disease, often not until they're about 30 years of age. The moment you see somebody failing at 30 years, you got to think as a transplanter and saying, okay, we're going to get this person transplanted, but they're going to fail again. And again, they're probably going to receive 2 or 3 transplants in their life if they don't have any problems, right? And this is not, and so this is no longer a benign disease as it's been taught in the textbooks. And it obviously requires a kidney biopsy for diagnosis. And there are no real validated serum or urine diagnostic biomarkers. While we showed some of those complement tests, those are not prerequisites or not appropriate in the diagnosis of IgA nephropathy. And you've already seen this in terms of the staining pattern, so I'm not looking at the clock, so I need to go a little faster. So we have, every one of you knows this, and one of the things that's coming out again and again is that when you do protocol biopsies, the people that develop problems with recurrent IgA nephropathy are those that have the IgA deposits and also C3 activation. The people that don't have the C3 activation just have deposits. Most of them will have deposits, so that's something to keep in mind when you're looking at these biopsies. So, like I said, 15 to 40% of these patients progress to kidney failure within 10 to 20 years of diagnosis. There's variability in how this happens. I want to get to the meat slide because you all know this. And there is a pathologic score there that is involved there. It's called the MESC score. And it talks about mesangial hypercellularity, endocapillary cellularity, segmental glomerular sclerosis, which is S, and the tubular atrophy and interstitial fibrosis, which is all graded. And they have cellular or fibrocellular crescents. Notice that this is the only classification system that exists right now, which is carried out in various forms, but nobody talks about complement in this. So that's a huge hole there because that's not being talked about. And so there is a KDIGO algorithm that's available that talks about, finding this IgA dominant glomerulonephritis and how do you actually treat this. Has nothing specific about treatment other than, support these people with RAS inhibition and other things and SGLT2 inhibitors at this point, and enroll the patient in a disease registry or start commencing supportive care. There's nothing out there. And that's where most of us have spent our careers, is basically preparing these people for a transplant. And so that's where understanding the disease potentially can help us guide better therapies and journeys for these patients. Let's talk about C3 glomerulonephritis. A lot of us just called it membranoproliferative glomerulonephritis as we were growing up, 1, 2, and 3, and so on. So we call it C3 glomerulonephritis now. And it's a complex problem. It's characterized by C3 deposition in kidneys by definition. There are 2 main subtypes, complement 3 glomerulonephritis or C3 glomerulonephritis, and dense deposit disease or dense DDD. And this is a truly rare disease. There's an estimated annual incidence of 2 to 3 cases per million, and affects individuals of all ages, starting early in childhood and young, so mainly in childhood and young adulthood. And it's very similar incidence in men and women. And all of us know this is something that comes back in the transplant, especially the dense deposit disease. And a lot of folks were very, very hesitant to transplant these patients, especially with living donor kidneys, because you didn't want to, get rid of a living donor kidney really quick. Without belaboring the point, hematuria, proteinuria, and the nephrotic syndrome can be features. And the other thing that should point towards is an acquired partial lipodystrophy and ocular complications such as drusen, which are complement-mediated if it can occur in the eye. And these are found in not an insubstantial number of patients, about 10% overall. And these patients can be very stable for years despite persistent proteinuria, although they can have fluctuations and episodes of acute kidney deterioration. And again, the alternate pathway is now known to be very well involved in this disease. And as you know, to recollect from what Susan said, the AP constantly generates low amounts of C3b via a tick-over phenomenon because it's always going on. And there's an amplification loop where the pathways all converge. And there are regulators there in factor H and factor I, and there's a promoter, which is properdin, which is involved here. And so if you think about what goes on here, In this disease, genetic abnormalities can occur in about 25% of patients. So this is where, genetic testing may be helpful in some situations, especially as you're screening living donors and so on. And it requires initial laboratory testing. It requires a confirmatory biopsy, obviously, to define the disease. And there's further assessment of complement activation, which can help you define, therapeutic opportunities in a care pathway for these patients. And by definition, immunofluorescence shows the dominance of C3 and over other than any other immune reactant, and it requires a twofold dominance of C3. And the alternate pathway activation is underscored by the prominence of C3 in the absence of C4d and C1q. So it also requires electron microscopy, where the electron microscopy can show you the difference between the subendothelial deposits of C3 glomerulonephritis on the left and dense deposit disease, which has these highly osmophilic deposits which are there in the capillary loops. And actually, just last week, Dr. Sethi from the Mayo Clinic presented some mass spectroscopy data at the Coronado conference, which suggests that these dense deposit diseases, deposits may actually be ApoE, apolipoprotein E. So, and kind of goes in, if you think about partial lipodystrophy as a presenting feature, it makes sense that something might be going on there. More to come on that. Just saw that, and a lot of us were excited about this. Us nephrologists, surgeons, we get excited about these things, even if we can't do a thing about it. So sorry if you don't share my exuberance about it early in the morning. So to summarize, it requires you can do these various tests. You can test for alternate pathway activity. You can test for factor H antibodies. You can test for factor B levels. You can test for BB levels, which will be high. Factor B is typically low in these patients. C3 is often, And so C3 is usually low in the serum. CH50 may be normal in these patients. And C4 is usually normal. Okay. So if an alternate pathway defect is detected, it is highly recommended that one do follow-up testing for factor H antibodies, C3 nephritic factors, and complement genetic panels, which are available through various laboratories. And the main thing to keep in mind is to make sure that you have these in a timely fashion appropriate to your clinical setting and not delay the treatment of acute patients. So the real challenge here is that it's a heterogeneous presentation, and it's similar presentation to other kidney disorders, which creates problems in the differential diagnosis. So it could be post-infectious genus, it could be an immune complex MPGN. So typically, the C3G has all of these things, both hematuria and proteinuria with preserved kidney function for a really good part of their lives. May present with acute nephritic syndrome, nephrotic syndrome. Post-infectious GN presents usually with hematuria, proteinuria, and a nephritic syndrome with hypertension that's pretty acute. And immune complex MPGN can present with hematuria and proteinuria of varying degrees. But those of you who treat patients know that this can occur across the spectrum, right? But C3G, the most important part, remember, is that when you see this in a young patient, nephrotic syndrome, and you have complement abnormalities, both on the testing and on the biopsy, there's something to think about. So I think I've hit this pretty hard. Let's basically look at the last piece of the immune complex MPGN. Pharma people will like acronyms. Most of my learning now is trying to get the lexicon around the acronyms. So the co-deposition of C3 and IgG and IgM and C1q and C4 can occur here, as opposed to not having the IgM and C1q and C4 in the C3 glomerulonephritis in the immune complex MPGNs. So these various levels of complement products can help guide a diagnosis. I'm not going to belabor that at 7 a.m. because I need a cheat sheet myself. So the prognosis here, and this is where if you remit spontaneously, that's very rare. It doesn't happen in a rare disease. And in 30 to 50% of patients will develop kidney failure within 10 years, which means they're going to come to people that transplant kidneys into these folks. And dense deposit disease is more likely to progress than C3GN to kidney failure, although the cumulative native kidney survival is similar. And post-transplant recurrence with allograft loss is a very important problem in up to 50% of patients with dense deposit disease, and overall 75% of people with C3GN, although we were always taught that dense deposit disease is much more a problem of recurrence. So to summarize, somebody in our team that made these slides, I think, likes knitting, because you have these balls of things, and I keep looking for a kitten to keep coming out of the left side of the slide, but nothing's come out yet. But anyway, so the complement system comprising the classical, lectin, and alternate pathways is a key part of the immune system, and recognition that the role of the complement system is being underrated in the past is increasing, and we know that its role in glomerular disease and kidney disease is being recognized increasingly. And it can be caused by autoantibodies, genetic mutations, which can cause alternate pathway dysregulation, and classical pathway and alternate pathway dysregulation, or lectin pathway and alternate pathway dysregulation. And you can end up with, when you have alternate pathway dysregulation, you probably have a C3G. When you have complement pathway, when you have classical and alternate pathway both being dysregulated, it usually comes up as immune complex mediated MPGN. And when you have the lectin and alternate dysregulated, it's usually the immunoglobulin A nephropathy, if you want to put it all together in the context of complement and not the traditional monikers that were applied to these diseases. Kidney biopsy remains the gold standard, but we're getting deeper into the kidney biopsy in a way that we should, and correlating with other things and phenotyping these patients better so that we may be better able to treat these patients. And that's where we are. I really thank you all for your attention. I'd highly recommend that you visit the renal halls of science, and please take down this QR code and do a survey on us and tell us, like Uber, we like to get a 5, okay? But that's all right, that's a joke. You can rate us however much you want to. But please visit the renal halls of science. We have some fantastic, what you saw as an animation and a video is only a glimpse of what is possible, and this is a great way to educate yourselves and your trainees and your staff, because there's more to come on this disease. And it's great to be back in transplant. At Novartis, we have 5 card-carrying nephrologists, 2 transplant nephrologists, and a fantastic bunch of people like Susan Lostetter who have a long history of engagement in transplants across some fantastic programs such as the Mayo Clinic and a whole host of PharmDs who bring a lot of experience in transplant and immunology to the field. So it'll be great to interact with all of you in the coming years as we do this together. Thank you.
Thank you for those insights. A lot to think about.